began as normally, as we always should begin, with the diagnostic part of our treatment. So, as I told you, it is very important to speak with the patient and extract all the informations that you need. Then, after a careful anamnestic procedure, you will think about what further investigations you may need. As I told you, the X-ray is the most common and most frequently used investigation. It's very fast and it brings a lot of information because, of course, bone is very visible on the X-ray. After this examination, of course, if we have a fracture that is communicative or is in a part that is has a 3D structure and it's harder to understand, it's also useful to do a CT. And of course, if we have lesions of the cartilaginous tissue, sorry for my English mistakes, we can do an MRI to see exactly how things are there.
Excuse me, I
Yeah,
think we're still on the first slide, and it's not in slideshow mode.
yeah, I'm not going in slideshow because it doesn't work. I don't know why, and I can't find out. So I'm using it in this way, but it's big enough. I think you can see it, right?
Okay, yeah, yeah.
So yeah, that I was on the first slide because I didn't begin the presentation. It was just a preamble, just a small discussion. Okay, so after we have identified our patient's needs and his discomfort, we can begin to do our treatment. What are the goals? As you can see here, the goals of treating fractures. Why am I speaking more about fractures and not on other subjects that interest the orthopedic field? Is because, as you will see, the most important thing for you to understand and learn in this short course of orthopedic surgery, it's very important for you to understand the pathology that is traumatic. Okay, you will learn a little bit also about arthrosis, coxarthrosis, so degenerative pathologies. Of course, one or two courses about tumors, but those are things that are treated by specialists and bigger and more skillful doctors. So the fracture is the thing that you have to learn and keep in mind because, for example, you will work in a hospital that doesn't have an orthopedic ward, and it's important to see a fracture, understand it, and know a little bit about its treatment so you can assess the patient and tell him to go to another facility that can treat his wounds. What are our goals for today, and what are the goals of the treating fractures? Of course, the first and most important one is is to restore the patient to optimal functional state. So a patient comes to us, he has a fracture, he cannot move his lower upper limb, and we will operate on him or maybe just immobilize him in a cast until his recovery. As you will see in orthopedic surgery and traumatology, all our pathologies, maybe not all, but most of them are treated very fast and very efficient. Yeah, we don't give medication for hundreds of years until the patient feels good. The patient comes to us and he has a fracture in the hip, he can't walk. The next day we operate on him and the next day he will walk. Okay, so this is the first thing, we have to do optimal functional state. Of course, we have to prevent other types of fractures and soft tissue complications. We have to keep this in mind when the patient comes to the emergency room and after we make an X-ray and an examination, we will assess the fracture and think about the lesions that can appear due to this fracture and what we have to do so they don't appear. For example, we have a patient that has a fracture of the supracondylar region. As I told you yesterday, we have a lot of we have a lot of vascular and nervous things there. Sorry, one second. No, Claudia. Și eu sunt acum cu microcursul cu studenții. Dacă termin înaintea lui operație, o să cobor. Dacă termin înainte să termin operație, da? Oricum, cu plăcere. Okay, so it's very important to assess the fracture. As I told you, in the supracondylar fracture, for example, we have the popliteal vessel and nerves there, and this fracture can damage this structure. So when the patient comes to the emergency room, maybe he is a patient that is old, that cannot be operated right away. So we have to immobilize that segment so we don't have more problems. For example, we can do a cast rather than a cast splint because we have the risk of compartment syndrome if you put a cast. Or, as you will learn in another micro course about bony tractions, we can do this type of traction and it will prevent other lesions in that region. You will see these tractions when you come on the ward. And prevent other fractures. What does that mean? If, for example, he has a spheroid long fracture, if we don't immobilize it correctly, that spheroid can transform in the community fracture. It is very important to get the fracture to heal, and to do that, we have to position it in a optimal functional position to recover. For example, if you have a fracture in the humerus, for example, and we will use a cast for treating it, not a operation, always we will keep the elbow in 90 degrees. Why? Because in 90 degrees, it's the functional position for the elbow. If, for example, we will put the elbow in too much extension or too much flexion, that elbow will be very painful in time, and it can block itself in that position through contraction of its capsule. Or another example, for the knee, always when we immobilize a fracture in the lower limb and we put, for example, a femorogambrial cast or a femorotibial cast, always we will keep the knee in flexion of 50-20 degrees. Again, this is the functional position of the knee. And very, very important, it is the last information on the slide, but it's also very important, the rehabilitation of the patient. Yeah, so our operations can go perfectly, the bone can look perfect, everything is back to normal, but if a patient doesn't use that segment and doesn't do rehabilitation, he could have important impotence in that segment. So we can see a patient, 25 years old, fracture of the tibia, we nailed it, it's perfect, but the patient comes after a month and he can barely walk. That is a problem because he doesn't have any more bone or muscle problems, but due to lack of rehabilitation, these problems can appear. So it's very, very important to tell the patient also to do some rehabilitation so that he has normal function again as soon as possible. Another important thing that you have to keep in mind and understand is how bone heals. We have different types of healing, as you can see here. We can have in nature healing, we can have operative healing, and operative healing can be through two types of healing. It's different when we use a plate and screws, and also different when we use intramedullary nailing. So intramedullary nailing and nature, so to speak, healing are very similar because the process is through, you can see here 3 phases, but there are 3 or 4 depending on the author, 3 or 4 healing phases of the calyx. We have the first stage when we have the hematoma that organizes and accumulates around the fracture. In this phase that takes from 7 to 10 days, we don't have any resistance in that region. Why? Because it's just a hematoma and some cells that are coming there, but they do not have any structure. In time, we go to the next next stage of callus formation. We have the fibrous phase when every structure there, the cells conglomerate and the collagen makes like a net, and all the cells come on that net, and we have some degree of resistance, but still the fracture can mobilize itself and it can evolve to a vicious callus. The third phase is when we have the bony callus. So we have a callus that has a lot of structure, a lot of resistance, but it's still not perfect. So it's not 100% exactly like the normal bone. You learn in anatomy about the Haversian canals. Those are the ones that give resistance to bone. And in this third phase, they are not really conform. The bone is just heterotopically displaced, so it's not perfectly rearranged. And in the fourth stage, that can take to 1 to 2 years, we will have the regeneration and the forming of the bone exactly as it was. So bone is the only tissue in our organism, maybe also the liver, but not so much as the bone, that can come back to its original state 100%. Okay, so we have these phases that come normally when, for example, we immobilize a fracture with a cast, but also when we do centromedullary nailing. We will do this without opening the fracture site. So we'll introduce this nail from the upper region or lower region of the fracture. So we'll not destroy the hematoma, and the bone will have the same type of callus formation, but with the intramedullary nailing, the fracture would have much more stability, and we can rearrange the bone much more better than we could do it with a cast. And the second type of callus formation is through to plate and screws, with plate and screws. In this case, we will open the fracture, the hematoma will be lost, and it's very important when we put a plate and screws to put back the bones in anatomical position. And again, very important, the displacement, so the space between the bones must be more than 5 to 10 millimeters. When we have this small space between the bones, or the perfect thing is to make compression. Okay, this is the thing that will help us, will help the patient regenerate faster. And in this type of procedure, we will not have all the phases of callus formation. We will directly go to the fourth stage. So we will trick, so to speak, the body in not knowing that he has a fracture there. So he will just rearrange the Haversian tunnels as he would normally do. This happens each day of each week of each month. So we have bone regeneration non-stop. So when we do the plate and screws, the bones will stay perfectly realigned and in continuity to each other, and we will bypass the formation of callus. The Haversian tunnels will be constructed directly through this means. Okay, so we have to keep this in mind. Another very important thing that helps us when we speak about traumatisms, as I told you earlier, yesterday, is the energy of the injury. We can have high energy injuries that are most frequently, as you can see in the image, in young patients, so from 20 to 40 years old. Could be sports injuries, could be traffic accidents, could be suicide attempts, could be anything that has an, could be, for example, but not so much in Romania, firearm injuries. Okay, so all of these injuries that vary to a very extreme force, they destroy the bone and, of course, all the other tissues. This is important to have in mind when we discuss about the high energy injury, that the force is so great that it doesn't destroy only the bone, rather also the muscles, the subcutaneous tissue, the skin, the fascia, and all of these things will destroy the structures, and the risk of septic evolution, the risk of malunion, the risk of pseudarthrosis is much higher than in lower energy. Traumatism is just a patient that is old, he has osteoporosis, so the bone doesn't have normal bone density, and through a small, just a fall from the same height, or maybe if we speak about a tumor process or a highly osteopenic patient, just a small hit with a very low injury could destroy the bone. But in these cases, very rarely we have lesions of the other tissue. So we have only the fractures rather than associated with other types of lesions. Of course, as I told you yesterday, but we will speak a little bit more today. After we described, we see in the patient, we make an X-ray, we see the fracture site and everything. We have to understand the configuration of displacement and, of course, the articular involvement of these fractures. Okay, so always understand exactly the anatomical site, so see exactly where the fracture is. Then understand if it's in the diaphyseal part, in the epiphyseal part, or diaphyseal and epiphyseal part. Then see if we have translation, if you have shortening of the bone, if we have any type of angulation. This is important to understand for both treatments, orthopedic or surgical ones, because we will have to reduct that fracture. And if we don't understand the muscles that pull on the fracture and how the fracture is displaced, it's impossible for us to reduct it. Maybe not impossible because we can train even a monkey to do some things, but it's important to understand and do things with knowledge about it, not just mechanical mechanical things. And again, very important to understand if it's an articular involvement, because any fracture that involves the joint can produce a destruction of the joint, the cartilage, and of course, evolution to a degenerative problem in the joint that will be very, very painful for the patient. Again, the dislocation about, I told you and I showed you some images yesterday, and destruction of ligaments, again, very important if we can or cannot reconstruct. Last but not least, the soft tissue injuries, as I told you, are very important through only through the concussion, so the destruction through shear force, or of course when we have an open fracture that destroys every structure in its path. For example, here is the most frequent fracture that comes to the emergency room, the distal part of the radius fracture that we have Put-Oppolz and Goran-Smith. So to speak, you will learn about them in the course about upper limb fractures. As you can see here, it's a fracture that is minimally displaced, but at the same time comes with a problem. I will show you again when we speak about this at the last course, when we will see all the X-rays. But we will have to see some angles and some things on this fracture to see if it's problematic or not. First of all, we will take a line that goes from the styloid of ulnaris and radialis, and the radius should be 10 millimeters distant from this line. So you can see here it's not 10 millimeters, so this is the first problem. The second problem, if we take a line that goes directly transverse through the radial bone and one that goes through the articular surface, it should always be palmar deviation, okay? So if you leave your hand without contraction, you'll see that it goes normally palmar deviation. Why? Because normally this angle that goes from here and here should be 12, 15 degrees palmar deviation. If you look here, it's dorsal deviation, so it's incorrect. So this fracture, it is minimally displaced, but it has to be reducted, as you will learn through orthopedic means. And of course, we have high energy fractures. As you can see here, a fracture that is in 3 fragments, 1, 2, 3, a butterfly fragment, so how we tell it, how we name it. This is a fracture that needs to be treated surgically because it cannot evolve correctly through orthopedic means because we cannot immobilize it correctly. Of course, when we speak about patients that come to emergency room, they can come through, I told you, a small trauma or a high energy trauma. So when we speak about high energy trauma, most likely we don't have just the fracture. We have also the lesions of the musculoskeletal, the musculotendinous part, but also other lesions. It could be a traumatism to the head, traumatism to the thorax or the heart or the spleen or the hepatic region. So we have a polytraumatized patient. So when we have a polytraumatized patient, we have to do some life-saving measurements. First of all, we have to diagnose them, of course. and understand what he has, because if we don't do this, we cannot treat it. Then we have to do some emergency orthopedic involvement that can save his life and decrease the complications. The emergency orthopedic management must be done in the first day and can be minimal. For example, just an immobilization, that just a external fixator. We don't do always high operation because they increase the risk of death in polytraumatized patients. Of course, we will monitor the fracture, and in the next stages, the next days, the next weeks, we will do a complete treatment of that fracture. And again, after we treat it, the rehabilitation is very important. I stress on this because it's very, very important. As you learned already, the most important ABC in medicine, emergency medicine, better said, are the life-saving measurements. As you can see here, the musculoskeletal region is just on E, so the fifth. Why? Because of course, if the patient can't breathe, can have normal heart contractions, we can operate him perfectly, we can do everything perfectly, but the patient is dead, so it doesn't help us a lot. So the discussion about there's a fracture, I have to fix it, is not so good in this type of pathology and this type of patient. So we have to keep in mind this short acronym. So first of all, A is airways and cervical spine immobilization. So we have to see if air goes through his airways or something is there that blocks it. And of course, immobilize his spine. Then we have to be sure that the patient breathes. Then to see if he has circulation. We have to see if he has any head injuries. And after that, we will explore and see exactly the injuries of the muscular system, because these are not things that kill you instantly. Now we're going to speak more about the orthopedic part of the life-saving measurements. We have some things that are emergent, are an emergency orthopedic. First of all, the fractures of the pelvis. Okay, so any fracture of the pelvis can be very problematic for the patient, because if you have an unstable fracture of the pelvis, we will have a hemodynamically unstable patient. What does this mean? That he will lose a lot of blood in his pelvic region or retroperitoneal region, and he could be dead in 1 to 2 hours. So it's very, very important to assess this and immobilize it as soon as possible through applying of pressure or, of course, reducting of the fracture. As I told you, it's very important to early diagnose this patient. So you can see here, fracture of the pelvis, a fracture that you can see is very, very unstable. It's a type C tile fracture. I'm not going to go in this discussion because that's important for you, but it's a very, very important displacement that is unstable rotationally and vertically. This is the most unstable type of fracture, and our treatment must be through a external fixator, because it's the only way to immobilize the fracture. Of course, we could do this open, but when we do this open in this type of fracture, in this type of patient, the risk is very high, because when you open this, you will create a space that doesn't confine itself. Okay, so the blood can come out in every part, and he will lose much more blood than if we just put an external fixator without opening. Here we can see an opening because in some cases, for example, you have a lesion of the spine, he has a lesion in the rectum or something like that, in the inferior digestive system. You have to do a exploratory laparotomy, so you open it and see exactly from where the blood comes. But these are things that are much more complex. I'm just speaking about some ideas so you can have in mind, because each patient has to be treated differently, because each patient has a different type of pathology. Not all of them have the same thing. The problems with open fractures are, first of all, the skin that can destroy the skin, and you can have ischemic necrosis. Of course, we can have muscle destructions that can go to compartment syndrome. So in the calf or in the antebrachial region, because of the tension that comes through the fracture and the accumulation of blood, the patient can develop this type of compartment syndrome that is very, very problematic and has to be treated as soon as possible. Of course, we can have lesions of the blood vessel through vasospasm, through traumatism, or even lacerations of the arterial parts, and that need to be sutured or grafted. The lesions of the nerves can be neurapraxis. This means just a concussion to the nerve is not destroyed completely, and it will come back in time. The axonotmesis, when we have a lesion of the myelin sheet, but not the whole axon, and it's easier for the patient to recuperate. And neuromesis, when we have the complete destruction of the nerve. In these cases, the only treatment is the suture of the nerve. And of course, the lesions of the ligaments that can prolong joint instability or even dislocation. So this is how a patient with an open fracture could look like. Okay, this is of course an orthopedic emergency because the patient can lose a lot of blood through this. The risk of infection is very, very high, but the treatment is in most cases just with an external fixator. Why? Because the risk through a nailing or an open reduction with plate and screws can have an important infection risk. So in these cases, we just put an external fixation that immobilizes the fracture until a second operation when we will do a correct reconstruction of everything. Of course, in this type of patients, we will work together with the plastic surgeons and the vascular surgeons to make everything as good as normal as could be. As I told you, all soft tissues injuries are of urgent treatment. Open fractures, vascular lesion, nerves, compartment syndrome, and fracture dislocation. Those are the emergencies in orthopedics. And of course, after the treatment of the soft tissue, we need rigid fixation. It's very, very important. And as I told you, severe loss of this soft tissue can risk the malunion of bones. Again, the discussion with the history, comorbidities, first aid, reduction, splintage. These are things that I explained to you, and I will not tell you again, only if you want more, you can ask. After we see the fracture, we have to put two questions. Does the fracture require reduction? So some fractures need it, some don't. Some fractures are stable and some are unstable. For example, a stable fracture is a simple transverse fracture that when we just immobilize it, it's going to be really stable and it's not good. It doesn't need reduction. But in other fractures, as I told you and I showed you image earlier, some of them need reduction. We have to understand exactly the displacement and how that displacement comes to be through force, shear force, and of course the traction of muscles. And again, an important thing to ask ourselves and to keep in mind when we treat a patient is how accurate should this reduction be? So if we have a fracture that implies the articular surface, of course, the reduction has to be perfect, because if it's not perfect, it will evolve to degenerative arthritis. But if a fracture, for example, is in the diaphyseal region with a centromedullary nailing, we will do a alignment, but without perfect anatomical reduction. It's just important to keep the length correctly and the rotation correctly, but it doesn't have to be perfectly bone to bone. Okay, you will see all of this. I know I'm speaking a little bit abstract right now, but you're going to see all of this in all the courses, and we will see again when we come on the ward, and again the last two micro courses when we'll discuss about all the fracture that you will learn in our ward. For example, this is the fracture that can be reduced very easily through orthopedic means. It looks bad, but the vascularization in this region is very good. And as I told you, the articulations that make the shoulder are very mobile, and shortening is not a problem. The problem is if the fractures open, so if it destroys the skin. So in this type of fracture, a alignment is enough. But in this type of fracture, we have to reconstruct it perfectly. As you see here with plate and screws, we have to do the perfect anatomical reconstruction. Why? Because, as I told you yesterday, the antebrachial region and the elbow articulation is very, very important for our day-to-day life, because we do the pronosupination. And if we don't do this perfectly anatomical, then the patient will not have a normal pronosupination, and that is a problem for him. After the reduction, we have to keep in mind how are we going to maintain this reduction through a semi-rigid reduction, a plaster, or a rigid one through internal fixation, for example. And when you do the treatment, you have to keep in mind how and when the patient can load the injured limb is different from fracture to fracture, when the patient is allowed to move the joints, and how long should we immobilize that fracture. We have to keep this in mind and always explain to the patient everything, because it's very important for him to understand his pathology and how it will evolve in time through our treatment. This is an image that is very symbolic and very easy for you to understand the types of treatment in the polytraumatized patient. As you can see in the right image, it's a patient that was treated first of all with an external fixator because he had the fracture of the tibia, but also a compartment syndrome. So you can see large fasciotomies were made and then skin graft put on. And in time, after the bone healed and the skin healed, we can do, as you can see on the left side, a centromedullary reduction that is much more strong, because, for example, on the external fixator, the patient cannot walk, but after the intramedullary nailing, he can walk the next day. So this is the patient that was treated directly in the emergency room in the first or second, maximum second day after the fracture. Of course, the fasciotomies were done in the second day, but the skin grafts were done after 1 to 2 weeks. Okay, and then the treatment, the terminal treatment with centromedullary nailing, and the patient can walk again. Of course, there are differences between the non-operative and the operative treatments. Of course, the rehabilitation is much more faster in the operative, because after we put a nail, the patient can walk the next day, of course, depending on the fracture. But when we treat it orthopedically, he can keep, for example, for a fracture of the tibia, can have a cast for as long as 12 weeks. So rehabilitation is a problem. The risk of stiffness is much lower in operating types, because the patient can move the next day when we immobilize it if he can't move. Med union, of course, is lower in operation. Non-union is present in both of them, because the risk of non-union comes through multiple things, not just the type of fracture, rather than if the patient has diabetes, if he's a smoker, if he's obese, if he has renal problems, if he has any hepatic problems. All of these things come together and can be problematic for the bone regeneration. Again, as I told you, the speed of healing is much higher in non-operative or in centromedullary nailing types of operation, because we do not destroy that hematoma and the rehabilitation is fast. But in plate screws is a little bit slower, because it's a different type of direct callus formation. The risk of infection, of course, in non-operative is much lower, because we don't open it, so it's easier to understand why they cannot evolve in most cases to infection. But in operation, of course, the risk of infection is here. Of course, because of the evolution of orthopedic surgery, in most cases in the last 30 years, we operate much more than we had 30, 40 years ago because we have much more means to do that, not because we are more we are also more skillful through the treatments, but because of the evolution of treatments, we can use different types of orthopedic devices that help us operate much more efficiently. The absolute indications for operational polytraumatism, displacement or intra-articular fractures, open fractures of course, any lesions of the vascular or nervous system with the compartment syndrome, non-unions or other pathologies related. Relative indications, the loss of position when closed method. So after we reduct it with closed methods, if the reduction doesn't maintain itself, then we have to operate. If we have poor functional results with non-anatomical reduction, then we have to operate to reconstruct the site. Or fractures that are very poorly vascularized and they can evolve to malunion through this vascularization. Of course, children will form a callus much more faster, as you can see here. How do we know that we have a callus? Once when we see the bridging callus formation and then the remodeling, and through the biomechanical, through our clinical examination, we can see that the patient doesn't have any more movements in the fracture site. Again, stressing you with the rehabilitation is very important. It helps us treat a lot of fractures that normally and without this type of rehabilitation could go very wrong. So it's very, very, very important to do rehabilitation because it helps us contract our muscles, keep our muscular tonus alive, and through this tonus and contractions, the bone will understand that it has to come there and put more callus and remodel the structure to its normal state. Of course, as everything has, also fractures have complications. Some are general, some are local, and some are early and some are late. General early, anything can come through a fracture, a thrombus, a lesion of the vascular system, the soft tissue, anything that is in that region, or different types of infections in the chest infections or urinary tract infections. Bones, early infection or malposition, late non-union, malunion. And for the soft tissues, different destruction of this, any soft tissue that is in the region. This is early and late, the rupture of tendons, the compression of nerves through the development of callus, or even Volkmann contracture that comes through a compartment syndrome that is not treated correctly. Okay, so this is the micro course about the treatment. Again, it's not very much in detail, but it's just so you can keep in mind and have some basic information. You will learn about this much more in the next courses. If you have any question, please.
I think it was clear. Thank you.
Okay, thanks. Okay, then I don't know if you spoke with Dr. Cursaro, I spoke with him yesterday, and he told me that you are going to come on the ward after your break. Okay, so
Yes, you know what I wanted to ask you? Are we going to have a schedule, like one group every day, or?
Yeah, you're going to be like 2 groups every day, I think.
Okay.
And we're going to speak exactly, I don't know exactly how we're going to manage, but we're going to see exactly because we are a lot of assistants, and so you will have, you're not going to stay all together, we're going to stay in different groups.
I understand. Okay.
Okay.
Thank you.
Yeah, no problem. Okay, then if there is no